Good morning and welcome to the fourth meeting of the Health, Social Care and Sport Committee in 2025. I've received no apologies for the meeting. The first item on our agenda today is to take evidence from the member in charge of the bill, Liam MacArthur MSP, as part of the committee scrutiny of the Assisted Dying for Terminally Ill Adults Scotland Bill at Stage 1. I welcome to the committee Liam MacArthur MSP, who's joined by Claudia Bennett, Senior Solicitor, Legal Services, Scottish Parliament, Nick Hawthorne, Senior Clerk, Non-Government Bills Unit, Scottish Parliament, and Dr Amanda Ward, Advisor to Liam MacArthur. Before we move to questions, Mr MacArthur, I believe you would like to make a brief opening statement.
Camilla, can I also apologise for the state of my appearance in cycling into Parliament this morning? I hit a pothole and the bike went from under me, so it's not an attempt to play the sympathy card with the committee, but it's certainly a reminder of the value of wearing a cycling helmet. So let me start by declaring relevant interests. I received funding for an additional member of staff from 3 permissible donors, Friends at the End, Dignity in Dying and the Humanist Society Scotland. And this support is currently 1 day per week. The Humanist Society Scotland also fund the development, maintenance, cost of the domain and hosting of our website I've used to publish materials relating to the bill. And Dignity in Dying also paid for my costs associated with a visit to California last year as part of a cross-party delegation of MSPs which met with various organisations and individuals in relation to the state's End of Life Options Act, and refer members to my register for further details. Turning to the substance of the exchange this morning, I introduced the Assisted Dying for Terminally Ill Adults Scotland Bill in March last year, following the usual member bill process and supported by the Non-Government Bills Unit. The bill's aim is to allow mentally competent terminally ill adults in Scotland to voluntarily choose to be provided with assistance by health professionals to end their own lives. It sets out eligibility criteria and processes for assessment, all of which contain, I believe, appropriate safeguards. The bill also includes requirements for data gathering, reporting and review. This is the culmination of years of campaigning and work by individuals and organisations, including current and former members of this Parliament. And there were previous introduced proposals and bills on this issue by Patrick Harvey, the late Margot MacDonald and Jeremy Purvis. And I thank all those who've been involved in seeking a change in the law on this issue and all who have supported me. I'm acutely aware of the weight of responsibility that comes with leading a bill on this issue and of the responsibility that rests on every MSP. We owe it to our constituents, whatever their views, to consider and debate this thoroughly and respectfully to ensure any bill passed is appropriate, safe and fit for purpose. I know that responsibility is one this committee has taken seriously, and I thank you for your detailed and robust scrutiny to date. I appreciate the committee has faced difficulties in taking oral evidence from people who will have been most directly affected, i.e. Those with a terminal illness. However, I know there is a large amount of powerful written testimony received by the committee to its call for written evidence and indeed to my consultation back in 2021. As members will be aware, the fundamental reason the bill is before Parliament is because of a belief in the need to give terminally ill adults more choice and control over their end of life and the means of avoiding the existential pain, suffering and symptoms often associated with terminal illness. It's worth emphasising, however, that this will involve a relatively small number of people each year. I've paid close attention to the evidence the committee has received. I've heard the support that has been expressed by many and I've listened carefully to the concerns raised by others. I'm aware of areas of the bill that have attracted particular focus, such as at what age assistance can be accessed and how capacity should be defined and assessed. I'll continue to listen to views on these points and to consider if the bill requires amendment. Another area of focus has been the definition of terminal illness. The bill requires a person to have an illness, disease or condition which is worsening and will continue to worsen and that is at an advanced stage. The illness must be one a person will not recover from and which is expected to result in their early death. I don't believe the definition should include reference to a prognosis period, and no strong case has been made for that. I remain confident that the definition gives clear effect to the policy intent, which is to capture terminally ill adults in the final stage of their illness. I also listened carefully to views on the assessment process. I believe the safeguards in the bill are sufficiently robust. A person has to be deemed eligible by 2 doctors acting independently, with both doctors able to refer to specialists for views regarding the particular terminal illness and/or capacity. Scope to involve other relevant practitioners where appropriate is also an option. In terms of the end-of-life process, my policy is that the life-ending substance must be self-administered. I acknowledge some concerns have been raised about this, but as the committee has also heard, there may be a variety of options available to support self-administration. In all of these areas, the approach I've taken is to achieve what I consider an appropriate balance between ensuring access to assistance in a timely fashion within a manageable process, and ensuring that appropriate safeguards are in place to protect people, including those who may be more vulnerable, and which respects the rights and choice of practitioners not to participate. I don't underestimate the sensitivity of this issue nor the significance of making the change proposed. As the committee has heard, however, doing nothing, the status quo, has consequences, given what we know to be the experience of those who endure a bad death, despite the best efforts of palliative care, or indeed those who feel forced to take matters into their own hands. We can and must do better, Convener, and this bill provides us with an historic opportunity to do so. I thank you for your patience and very much look forward to answering the questions of you and your fellow colleagues.
Straight to questions, and Emma Harper.
Thank you, Convener. Thanks, Convener. Good morning. Just waiting on my microphone coming on there. Good morning, Mr MacArthur. I'm going to just ask a couple of questions about eligibility criteria and the definition of terminal illness. And I know there's a bill going through the UK Parliament right now as well that is very similar. And so I'd like to explore the language of terminal illness in Scotland versus England and your views, which you said someone has to be terminally ill at the end stage of their illness. So can you describe to us the question or I guess concerns that have been raised regarding this isn't just about people with a diagnosis of cancer. It might be somebody that has a terminal illness like MND. Issues around Parkinson's has been raised. Other things where somebody might be unable to recover from chronic obstructive pulmonary disease, for example, or end-stage renal failure or cardiovascular disease that's really, really debilitating. So are you able to just give us a bit of an overview about the definition of terminal illness and how it relates to this bill?
Thanks very much, Ms Harper. I think the first observation I would make is that if you look at the jurisdictions that have in place a similar model of assisted dying around terminal illness and capacity, broadly speaking, you can see the conditions that patients that access it tend to have. So, in a sense, I think the expectation would be that would be replicated here in Scotland, and I don't think it would be necessarily very much different in England and Wales. As I said in my opening remarks, the expectation is, or the requirement would be for the terminal illness to be advanced and progressive. With the expectation the patient would not recover. And that's a diagnosis I think medics are used to making, are comfortable with making. Obviously, there's a requirement in this instance for it to be the diagnosis not simply of one medical practitioner, but 2. And I think that provides an additional safeguard. I think over and above that, where there's any sort of dubiety, any question in the mind of either of those practitioners, there is an option to refer on to a specialist, perhaps in that area of medicine. Possibly in relation to the terminal illness diagnosis, I think from the conversations I have with stakeholders and looking at what happens internationally, it may be more expected in relation to an assessment of capacity. But that onward referral, I think, is again an important safeguard to give confidence that the assessment around terminal illness is one that is robust and thorough and provides the protections that patients and the wider public would expect. And
just one of the things that's come up as well is the language of unable to recover from versus untreatable, because the language is really needs to be very precise. And I know that people we've had some conversations around this unrecoverable, and that's because treatment options have been explored, delivered, maybe agreed upon, or then even not proceeded with. So tell me then about the use of the language unable to recover from rather than untreatable, because in some of the language that's been used, is like somebody who has an eating disorder, for instance, might see that they have no option to recover from that. But that is something that, as a healthcare practitioner myself, I'm still a nurse, is that how do we make sure that this language is so definitive when it's about unable to recover from?
I think I would observe, I mean, I've obviously sat in on the oral evidence sessions the committee's taken, and I was, I think, encouraged and reassured by the evidence taken from BMA, Royal College of GPs, and the panel the committee heard from there, where there didn't appear to be any concerns around the way in which terminal illness had been defined in the bill. I think they were comfortable with the way that was set out, and indeed the further explanation in the supporting documentation. But I think the question that you raised, Ms Harper, is one that does crop up. I mean, I think there are clearly many treatments that can be tried and applied. Some may have some benefit in terms of slowing the progression of a terminal illness. But actually, I think defining this on the basis of a disease condition or illness from which the patient will not recover is important, because I think that separates it out from some of the conditions that have been raised that to my mind wouldn't meet the eligibility criteria, because in a sense there are options that would lead to a recovery. Now, whether or not the patient chooses to take those options is a matter for the individual patient, but they wouldn't meet the eligibility criteria set out in the bill, to my mind.
Okay, thanks. I think others are going to come to capacity, so I'll leave it there. Thank you.
I believe you've got a supplementary here.
Yeah, thanks. I was wanting to ask about age. And obviously the decision in the bill is that 16 is the age. There's good arguments for both 16 and 18. 16 is the in line with the age of legal capacity in Scotland, where 16-year-olds can make decisions about their medical procedures and treatments. 18, however, is the age under the UN Convention on the Rights of the Child. So there's good arguments for both. So keen to hear a bit about what you did in coming to your decision for 16, what consultation you did, who you spoke to. And
I mean, I think you've summed it up very well, Mr Fitzpatrick. I think you can make a strong argument for both. The rationale for opting for 16 was on the basis of that being the age of sort of adult capacity for making medical decisions. Those who are 16 are able to are deemed to have that capacity in terms of decisions around their treatment. So I think there's a logic for 16. I think there's a very defensible case. That said, I've also heard the evidence that the committee has had in relation to the case for 18. I know that in other jurisdictions, whether in Australia, whether in some of the states in the US, 18 is the age at which an assisted death can be accessed, and obviously the bill that's been introduced at Westminster has a similar age limit. So it's probably an area where I'm keen to reflect further. Should the bill pass at stage 1, looking ahead to stage 2, as I say, I've taken cognizance of what the committee has heard, and I think the arguments for setting the age level at 18 are persuasive, but as I say, I think the reason for opting for 16 is that, in a sense, that's the age at which individuals are deemed to have capacity to make a range of decisions in relation to their care and treatment.
Did you have any engagement with young people, 16 to 20-year-olds, around that in terms of coming to that conclusion, or is that something that maybe needs to be done if we're going to change it?
Yeah, I think absolutely there would need to be that further engagement. I suppose I would observe the Commissioner has taken a close interest. In fact, successive Commissioners have taken a close interest in this issue and have expressed views in the Scottish Youth Parliament as well. Again, have had campaigns on this issue in support of a change in the law over successive sessions of the Youth Parliament. I mean, it clearly is an issue that engages younger people. I think the assumption often is that this is solely an issue that, in a sense, kicks in for people later on in life, but that is absolutely not the case. And I think what you see probably in the written evidence you will have received, certainly I saw that in the response to the consultation I issued, young people have very clear personal experience to draw on, often of older family members who have perhaps gone through a bad death. So they feel very invested in this, and therefore I think if the age limit was to change, it would need to take account of any concerns they might have. I think the only other thing I would add is the numbers that are likely to seek to access an assisted death in any given year are going to be relatively low. I mean, I would have said around 1% of the overall numbers that die in any given year. And so the numbers at that end of the age spectrum are going to be exceptionally low, and possibly even zero figures over a given year. That's not to say it's not important to take those views into account, and actually some of the concerns that I know Chas have raised with the committee I'm very cognisant of, but I think it would be important to emphasise that the numbers involved here are likely to be exceptionally low indeed.
Thank you.
The bill would require someone to be ordinarily resident in Scotland for 12 months before they'd be eligible for assisted dying. And last week in evidence, Police Scotland raised questions about what was meant by the term ordinarily resident. So I'm keen to explore why that definition was used and what ordinarily resident actually means in terms of the bill.
I obviously sat in on that evidence session. I was very interested to hear the comments. I suppose ordinarily resident is phrased in such a way as to accommodate for situations where individuals may be working out with Scotland for a period. They may be on holiday, possibly a prolonged holiday, but to all intents and purposes they live in Scotland. They are registered with a medical practice, which is also a requirement under the bill. I think the terminology is fairly commonly used in the law in Scotland, perhaps less so in terms of the criminal law, which is perhaps where Police Scotland are come into contact with this more often. But I don't see it as being problematic. It's more, as I say, trying to acknowledge that somebody may be resident in Scotland, but over the course of a 12-month period, may be outside Scotland for weeks or months at a time, whether for work, whether for personal reasons.
Tightening up to define what it actually means, and so the concerns that were raised at that committee hearing about people travelling to Scotland, setting up I suppose a temporary address here to access assisted dying.
I think ordinarily resident, as I say, is a legal concept that is understood. I mean, I noted the concerns that Police Scotland raised. I would be interested to know whether there was an alternative definition that they felt would address the concerns that they have. But I think it's, as I say, I think it's a concept that is fairly well established, and whether there's a way of defining it on the face of the bill any differently, as opposed to what is set out in the explanatory notes and the policy memorandum to the bill, which I think makes it clear what the policy intent is. So, again, it's one of those areas where I'd be happy to reflect on any changes. But I think sitting alongside the requirement that somebody is registered with a GP probably gets round the concerns. As I say, I can understand where Police Scotland may be coming from because of the way in which they engage more often with criminal law, and maybe that is where some confusion perhaps arises. But I'm fairly comfortable that isn't a concern that's been raised by others, and that, as I say, it's a concept that's pretty well established and understood.
Thank you. Sandesh Kohana.
Good morning, panel. A declaration of interest as a practicing NHS GP and chairing the Medical Advisory Group. With today being World Cancer Day, when we have 35,379 new cancers registered in Scotland in 2021, which is an increase of 5.5% from 2019 figures. Now, whilst I appreciate not all cancers are terminal, some are, and as we live longer and we have an increasing number of cancers, that would then occur with more people being terminal. And one of the issues that we've heard previously is about the palliative care sector and how the palliative care sector is relatively underfunded. And those who provide end-of-life care are sort of struggling at the moment. And given that we're really struggling to cope with the demand that people have at the moment, without further money going into the palliative care sector, there is a criticism that some would turn to assisted dying because they cannot access palliative care. How would you respond to that?
It is, as you say, Dr Gulani, it's one of the concerns that's very often raised. I think it's important that we avoid seeing this as a zero-sum game, an either-or. I think we do need more investment in palliative care, particularly around access. I mean, I think there will always be improvements that we want to make in terms of palliative care, but the issue that seems to arise more often than not is one of access rather than the quality itself. I think also an understanding that palliative care isn't just at the specialist hospice end. I mean, palliative care is more often delivered by doctors, nurses in other settings. And I think what has been clear from the debate around this issue, around my bill, is that the needs of palliative care are ones that are given less attention in the overall debate around health and care services than other parts of the health and care setup. And you can perhaps see why that is the case, given the pressures on some other parts of the health service. But I think one of the real positives about this debate is it's shone a light on those issues, but it's not an either-or. We need both. We also know, again, looking at jurisdictions around the world that have not just a terminal illness model, actually the more expansive models hold true in this respect, but from the States and the US, from the States and Australia, where a similar model has been introduced in more recent times, we see that the vast majority of those that are accessing an assisted death are in some form of palliative care or have had access to palliative care. And therefore, it demonstrates that these are people who have, to their mind, exhausted what palliative care can provide for them, and that this is the choice that they opt for at that point. I think the figures in relation to Oregon most recently, around 90% are in receipt of palliative care or have had palliative care. In the States, in Australia, Victoria, Queensland, I think the figures are north of 80%. And again, that's a fairly consistent picture. So we do need to improve access to palliative care. As I say, I think the debate around this bill has provided a platform for those in the palliative care sector to make that argument. But I would caution against seeing this as an either-or, because, as I say, overwhelmingly those that are accessing this in other jurisdictions with similar models and other types of models, they are in receipt of often the best palliative care, and what this demonstrates. And as palliative care practitioners themselves would acknowledge, palliative care can do wonderful things, but it can't always meet the needs of those with a terminal illness, and that's what's reflected, I think, in the figures that we see.
Thank you for that. And so we've also heard from previous witnesses that by passing the bill, we will open the door to a slippery slope or mission creep or scope creep. And they cite, just as you have there, Canada, Oregon and the Netherlands as examples. Do you think that that will happen here through legal challenges? And how do we safeguard against it?
Again, I think the slippery slope argument is one that is consistently made. I think I would point the committee to the report published by the Health Committee in the House of Commons in February last year, at the end of an 18-month inquiry into assisted dying and end-of-life choices, which concluded there was no international evidence of a jurisdiction that had introduced a terminal illness mental capacity model similar to the one that I'm proposing and that's been considered by Westminster at the moment, where the eligibility criteria have changed. That was, I think, confirmed in the evidence the committee heard from the witnesses involved in the process in Australia. I think in Oregon, while there have been minor changes, for example, to the residency requirement, where I think it was found over the years that the residency requirement didn't provide any meaningful safeguard at all, and therefore it was removed. But the eligibility criteria of terminal illness and mental capacity hasn't changed. I think the argument that one of the witnesses was making to try and substantiate the claim of a slippery slope in Oregon is that different conditions were featuring to a greater or lesser extent in terms of who was accessing assisted dying. But I don't think necessarily that says anything other than that patient confidence, medic confidence in the procedures perhaps evolves over time, that those with certain conditions find that the palliative care that is available meets the needs up until a point, but they find themselves beyond that at a certain stage. I think with Canada and the Netherlands, I've always acknowledged that those are more expansive models. They've always been more expansive models. In the case of the Netherlands, that has been over very many years. The Canadian model that is very often cited has evolved. It's evolved through court process, which is sometimes kind of brought into the debate here as somehow a risk. But the constitutional arrangements in Canada are very, very different to the ones here in Scotland and in the UK. So the introduction of the legislation came about as a result of a case brought before the Supreme Court in Canada on the basis of the Canadian Constitution that the ban on assisted dying was unconstitutional. Parliament then introduced legislation. It wasn't felt to go far enough. It was then legally challenged under appeal, which was upheld, and the scope was expanded further. So the arrangements in Canada and in the Netherlands, both of which enjoy, again, overwhelming public support, are very different than what is being proposed here. And that, as I say, I think there is no example of a terminal illness mental capacity model having been introduced, whether in the US, whether in Australia or New Zealand, where the eligibility criteria have changed.
Final question, because we are very short for time with the amount of questions we have. We heard from the disabled groups, and they were very clear that nobody that is disabled supports assisted dying. That's the evidence that we heard from the groups. And how can this bill ensure that we don't allow vulnerable groups, as we heard about disabled people, being pressured into using it rather than accessing other forms of treatment?
Well, I think the perception that those in the disability community are overwhelmingly opposed to a change in the law isn't borne out by, I think, the evidence that the committee will have heard from Professor Colburn, University of Glasgow. It's very comprehensive research, kind of points to both attitudes within the disability community, but actually the international evidence of how this is accessed. I think polling consistently shows that support for a change in the law to allow for assisted dying is every bit as strong amongst those within the disability community as it is in the population at large. So the kind of mid to high 70% in the main. I understand the concern around the way in which those within the disability community often feel that their lives can be devalued, that their access to rights that they have isn't realised consistently, or that there are rights that they at the moment still don't have. And in a sense, I would stand in solidarity with them in terms of improving that situation. But we don't improve that situation by denying terminally ill adults the right to an assisted death where they choose to do it. I think it would be wholly intolerable for somebody with a disability that had an advanced progressive terminal illness and mental capacity to be denied the same access as an able-bodied person to the choice that is set out in my bill. I think those in the disability community would rightly be up in arms in those instances. So I think all I can do is offer the reassurance that having a disability does not make you eligible to access an assisted death. You need an advanced progressive terminal illness and mental capacity in order to be able to access it. If you have a disability as well, I see no reason why you shouldn't be able to access that in the same way. If that needs further support in order to be able to access it, so be it. But I think, as I say, I think this is recognised broadly within the disability community, which is why, as I say, polling consistently shows very strong support for a change in the law.
Thank you.
Brian Whittle.
Thank you, Convener. Good morning, Mr MacArthur. Just a very quick supplementary around that vulnerable disability group. We had a round table in Parliament where we had a variety of really excellent contributors. One of those was the father of and had guardianship of his adult son, who had a learning disability, and he pressed us really hard around the human right of his son should he request assisted dying, but he has guardianship of his son. Where does the bill fit with that scenario?
Well, I'll maybe bring Amanda in on the specifics here, but as I say, I think the capacity assessment that would be required in order to be eligible is a capacity assessment in relation to the choice of an assisted death. It isn't a broader capacity issue, where support can be provided in order to allow an individual to make that assessment. That would be expected to happen. And therefore, I would hope that that would allow access for as wide a range of individuals who meet the eligibility criteria to have that choice. But Amanda, is there anything you can add?
To come on, I would just point to the fact that, as with guardianship, advance directives have been raised in the committee as well, and the bill is very clear that the request must come from an adult with full mental capacity. And as Liam has said, we have made provisions in there for proxies and other things where people need support to do that. But where a guardian, someone with guardianship, to try and take a person through that process, that isn't something that the bill allows for, in the same way that the bill does not allow for advanced requests, because the person must have mental capacity at the time of the request, right through the patient pathway, and then until the moment when they would self-administer the medication. Section 3(2)A of the bill is quite specific as well around mental disorders, and you are, if you're suffering from a mental disorder that would affect the making of an assisted dying decision rather than just a broad mental disorder, then you would be excluded as well under the eligibility criteria. So to answer your question, someone with guardianship couldn't take his son through that process unless his son qualified under all the eligibility criteria in the bill.
Paul Sweeney.
Thank you, Convener. Thank you, Mr MacArthur, for attending today. Further questions were raised by witnesses in terms of practical administration of a substance if someone was physically impaired and unable to do so. Obviously, we mentioned proxy in terms of the certification and so on. Just wonder if you could talk us through the practical application of administering a substance if someone was physically unable to do so due to paralysis, etc.
Again, I think MND Scotland, for example, I think we're particularly strong on this point. I mean, self-administration is integral to the proposals I've brought forward. I think on that same panel there was an acceptance that there are other means whereby that self-administration can take place. Whether by signalling through eye movement and other mechanisms. I think what is important is ensuring that there is the capacity and intent, but I think the development of medical technologies is now allowing that self-administration to happen in a way that would have been very difficult to conceive of a number of years ago. But I think it is important that self-administration criteria remains. And as I say, I think I'm confident that can be achieved while not excluding those who meet the eligibility criteria in terms of advanced progressive terminal illness and mental capacity.
Helena Whittam.
To remind members of my register of interests that I'm a member of the Humanist Society Scotland. Good morning, Mr MacArthur. Some of the questions that I was going to pose to you have already been explored a little bit, but I'll just go into them a bit further. So with regards to capacity, the ability of doctors to undertake potentially complex capacity assessments have been raised with us, and there's some issues expressing concern about the resource implications for this. How comfortable are you that our doctors have the ability to assess capacity effectively?
Well, thanks very much for that question, and absolutely it's an issue that's come up probably on most of the panels that the committee's heard from. I think I'm reassured that capacity assessments are ones that medics are making routinely in relation to a whole swathe of different treatments and care options. I think there's almost certainly additional training that will be required to make a capacity assessment in the context of an assisted dying process. But I would see that as augmenting or adapting the training that registered medical professionals are undertaking routinely. And I think obviously as expertise builds up, I think there's, and we may come on to this, what the support is for medical professionals that are involved in this process in terms of peer support, the sharing of information and understanding, etc., as well as the pastoral support. I mean, I think it's something where speaking to those who are involved in the process in places like Australia and the US, they very often point to it being one of the most fulfilling aspects of medicine that they've been involved in. But it may well be challenging for others, and therefore providing that wider support, I think, is almost inevitable. But I think in terms of making capacity assessments, those are things that medics are doing routinely. And while further training will be required in terms of the specifics of this bill, I don't see it as adding greatly to the workload or the pressure on those medics who would be involved.
Another issue I'd like to explore is whether your bill as proposed has actually taken into account the Scott Review and the outputs from that with regards to taking a human rights-based approach to capacity issues, and not just having capacity or not having capacity, but actually having a supportive environment that allows someone to be able to express their will clearly. What account does the bill take of that? Yeah,
I think that's interesting. It's obviously an area where there's an awful lot of work going on, not least in relation to the Scott Review. The bill is framed, I think, it very much in the context of where things stand at the moment. I think, as I say, it is the assessment is a capacity assessment in the context of the decision around an assisted death. And as I say, where additional support might be needed, and taking account of the comments from Dr. Ward earlier, that can be supported, but the capacity would still need to be established around the decision to opt for an assisted death.
Okay, and just to explore that a little bit further as well, in terms of mental disorder that's included in the bill, Dr. Ward's already made reference to that as well. Do you foresee the ability for those who perhaps have a mental disorder as defined in the DSM, which could include learning disabilities and things like neurodivergence, autism, etc., is there the potential for those individuals to have their capacity assessed under a human rights-based approach to it? So it's not that they just have it or they don't have it, but they have that support to have that assessed.
I'll bring in Dr. Ward in a second. I mean, certainly having a mental disorder does not preclude you from accessing the option under the proposals I've put forward. The capacity assessment would still need to be undertaken in the context of the decision around an assisted death, and appropriate supports could be put in to ensure that capacity was realised. But there may well be conditions where it's felt that does impact on the capacity in relation to making the choice around assisted death, and in those instances, therefore, they wouldn't meet the eligibility criteria. I don't know if there's anything else.
I would just point to the existing context with end-of-life treatment where there are neurodivergent issues or mental disorders, and how we currently support patients with that, and how we there are many ways and tools that we use to make sure that the decision is their own and that they have full capacity. So there are existing provisions in there. In terms of taking a human rights-based approach to it, that has been central to what we've done throughout. And if you look at section 3(2)(b), what Mr MacArthur has done in this bill, which hasn't been replicated in other jurisdictions, is laid out what the capacity test should look like. So, for example, in Westminster, you've been following closely, I imagine, the evidence that they've been taking this week. That bill just points to the current Mental Capacity Act, rather than just pointing to existing legislation, again, being cognizant of the fact that there are changes to mental capacity going on in the background whilst this was being drafted. We have tried to not just take account of the existing law in the capacity space, but also to itemise exactly what that capacity test might look like for someone. If I could just quickly pick up on the training, if that's okay, Convener, because it's relevant to the capacity issue.
On to further on, so if not, I'm happy to come back to it.
Thank you. I also have questions round about coercion. Coercion, like capacity, is something that your bill is looking for the healthcare professionals to assess. We've heard from some that coercion is very difficult to assess. What would be your response to that?
Again, I think, as with capacity, it's an assessment that is made routinely by medical professionals, albeit in relation to other contexts, but in terms of other treatment and care options. So it is part of the training that medics already receive. I think there's, again, probably an argument for saying that there may be adaptations that need to be made to that training in order to reflect the context in which those assessments will be undertaken. But the GMC set out very clear guidance around how to assess coercion. They also set out very clear guidance around assessments of domestic abuse and coercive controlling behaviour. So these things are in place at the moment. As I say, I accept that they may need to be reviewed and an assessment made as to whether changes are required, given the change in the law that this would introduce. But I'm fairly confident that that coercion, that assessment of coercion, can be made. And I think the other observation I would make is, at the moment, the point at which we are assessing whether or not coercion was involved is happening post-mortem. I mean, we know that those who are facing what they feel is a bad, undignified death are very often taking matters into their own hands, but there may well be other instances where coercion is at play. But because the individual patient cannot have that conversation with their medic, or indeed with other family members, where there is coercion at play, that doesn't emerge. Those conversations aren't happening. That only emerges after somebody may have taken their own life. So I understand the concern there is around this, but I think what my bill does is put in place protections that currently don't exist for many of those that are in a very vulnerable state near the end of life.
We've heard that coercion can be defined as making people act in a way contrary to their own best interests. Can I ask you to tell us about those with a terminal illness who have contacted you over this period of time that you've been working on this bill, who have spoken with you and feel strongly that the status quo does not work in their own best interests?
Look, I think I said in my opening remarks that personal testimony of those either with a terminal illness or who've lost somebody to what could broadly be described as a bad death has been what stood out to me as somebody who went through the process in 2015 and 2010 of the earlier bills. That has come through far more prominently as part of this process than was the case previously. More and more people have that personal experience. I remember sitting in this very committee room, actually, listening to somebody who themselves was from the state of Victoria in Australia, but had been diagnosed with myeloma. And he talked about his experience. He talked very, very warmly about the quality of the treatment and the palliative care that he was in receipt of. But I've got a quote from here. It says, "During my time in hospital, I got a taste of what be in store for me as my blood cancer progressed to terminal. It was horrifying, something that no human being should have to endure." I'd also was contacted by somebody from the Western Isles with MND, which was touched on by the Deputy Convener earlier on. I said, "I'm not afraid to die. I want to live. I want my life to continue. But right now, I'm living with extreme anxiety and suffering. For me, the assisted dying is, funnily enough, a lifeline. I could let go of sleepless nights, stress-filled days, and constant anxiety-ridden thoughts." So, as I say, this is one of those occasions where, and I've sat on the other side of the table, where, in a sense, the judgment you need to make is the change that you're introducing going to make things better? But at the very least, you want to avoid making things worse. I think this is an instance of a piece of legislation where the status quo has consequences. If we do not introduce this choice, then in a sense we are accepting that these individuals and others will continue to face these hellish options at the end of life, despite the very best endeavours of palliative care, and despite any investment we may wish to make in improving access to palliative care. And that, to me, seems absolutely intolerable. I think those voices absolutely need to be at the centre of the debate that we're having around this issue and inform the decisions that we take.
Thank you.
Carol Morgan.
Thank you, Convener. Good morning. I want to ask a wee bit about the service model. In our evidence taking, you will know that we had a lot of questions raised around, particularly the doctors involved. You know, would this result in doctor shopping, large numbers of doctors conscientiously objecting? How would we deal with that? So, some of the questions are around: do you think GPs are in a position to be the doctors involved, or do you think perhaps a specialist service might work better, and particularly that sort of opt-in service rather than opt-out? I just wondered in your views on those.
Yeah, no, I think that's been a really interesting element of this debate. I mean, as you'll be aware, Ms Mochan, I've opted to place this very much within the framework of health and care services. I think that's the most effective way of ensuring the safeguards, the more effective and efficient way of delivering the service. I do feel that it's something that needs to be seamless. The pathway for the patient has to be as seamless as possible, and this is an assisted death is one of a series of end-of-life options, and one of the safeguards, obviously, that is built in to the process is the discussion that needs to take place between the coordinating physician and the patient, to ensure that the patient is aware of all the options that are available, whether they're palliative care, social care, other types of health and care treatments, so that the decision itself is informed. But I think thereafter, and that may change over time, I think, as the committee's heard, prognoses are highly problematic, particularly in relation to some conditions, maybe more so than in others, which is one of the reasons I haven't set a 6-month time frame, which is a feature of other jurisdictions. So things may change over time. That may be an ongoing conversation that is had, but it is one I think that is safest for all concerned, embedded in the health and care service. So I think a standalone service I find problematic. I think expecting somebody to be kind of lifted and shifted out of a current pathway into another service at probably one of the most vulnerable points of their life, their final days, it doesn't seem to me acceptable. I think opt-in and opt-out, I'm perhaps more sympathetic to that, but I would need to understand how that would work in practice and how we'd avoid, in a sense, just creating unnecessary obstacles to people accessing the choice and accessing the option. And in terms of the numbers involved, I mean, obviously, in order to be able to carry out the work involved here, the appropriate training would need to be taken. But as we see from other jurisdictions, I think this is evidence I gave to the Finance Committee earlier. In terms of Victoria and Queensland, the numbers of registered medics are around 400. The number, I think, in Victoria that were actively involved in any given year in 23-24 was around 300. And in Queensland, I think the figure was almost it was half that, it was about 120. So the numbers that are involved are not terribly high. I think there would be a wider maybe expectation, the training requirement on those who may be not as directly involved, but who would need to be aware of what the law is, how they might signpost if somebody were to come to them asking for advice, and just maybe even just for their own peace of mind, understanding what the legal provisions are. So there is a training requirement there, but the number of patients, as I say, are likely to be very small, certainly in the first couple of years, gradually increasing as public awareness increases and as medic confidence increases and medics have the training they need in order to deliver it. But I don't see why there's any reason that in Scotland we would find difficulties in having the capacity to deliver this option that haven't been experienced in any of the other jurisdictions, Australia, New Zealand and the US, operating a similar model.
Can I ask, just in terms of the experience of the doctors involved, do you think, are you saying that you think that would need to be in the bill, that would be part of the medical profession to perhaps have guidance on that?
I think it would come through guidance. I mean, I can understand the frustration of the committee in wanting to understand with real clarity how this works in practice. Some of it absolutely must be expressed on the face of the bill, but the committee will understand from this and other bills that there will be elements that more appropriately need to be taken forward in secondary legislation, recognising that they will almost certainly need to be reviewed and revised and updated far more frequently, and a great deal more probably that will then need to be reflected in guidance from professional bodies and regulators and others. And that's, I think that's the appropriate way of taking this forward. But as I say, I entirely understand why, to some extent, there's a desire to see as much as possible on the face of the bill, and I would sympathise with that. I've hopefully done that as far as I can in this bill, and in the supporting documentations in the X notes and the policy memorandum sought to kind of flesh that out. But ultimately, you're right, some of this will have to await guidance. And I think for the purposes of the interests of patients and medical professionals, that's a reassurance. That's absolutely where it ought to be.
I just wonder, just with your experience having looked into this, and you've been to other jurisdictions, in some of the other areas there's institutional objections, but that's been questioned both ways, as you know, and I just wondered whether, in your mind, that was a good approach, or whether that was something you would avoid.
Yeah. No, I think I've probably not spoken enough about the conscientious objection here. I mean, this is fundamentally about choice, but giving dying Scots the choice, should they wish it. But that works both ways, and there absolutely needs to be a robust conscientious objection for medical professionals who otherwise would be involved to opt not to be involved, subject to, I think, an expectation that they would then refer on a patient to somebody who could provide that support. So that conscientious objection, that choice for the medic is fundamentally important. I think where I have a problem with an institutional objection is that is an organisation that may well involve and include individuals who are supportive of a change in the law. It ceases to be about individual choice, in a sense that can throw up, I think, more of a risk of barriers being put in place of individuals who meet all the eligibility criteria, who are protected by the safeguards that are in place, but find that they aren't able to access it because of an institutional opt-out. And we see that in other jurisdictions. It has proved problematic. I think, though, that there are ways in which that can be managed. I know from speaking to those involved in the hospice sector, for example, in New Zealand, that there's a mixed picture of the way in which individual hospices engage with it. So some may not directly be involved in the provision of assisted dying, but who allow practitioners into the hospice to help deliver the service. So there may well be a way of, in a sense, providing a more flexible approach that as I say, recognises the strong emotions and feelings that some people have around this, but ensure that doesn't stand in the way of individuals who meet the eligibility criteria accessing the choice which I feel they need to have.
That's very helpful. Thank you, Convener.
Ryan Whittle.
Thank you, Convener. The issue of palliative care was raised earlier by Dr Gulhani, and I want to explore that a little bit further. I think, hopefully, and not putting your words in your mouth, Mr McCarthy, but hopefully what you would agree with me that the ideal scenario is to have access to palliative care and as well as assisted dying. So you have access to both of those things. We know that's not the case. We know that 1 in 4 Scots are not getting access to palliative care. And one of the things you highlighted, and I think what this bill has highlighted, is shone a light on palliative care. So I think it's a very, very welcome thing that this bill has done. But I think there's, and the other thing we heard was the inequality of access to palliative care from, SIMD1 to SIMD5. So I think my question would be around: would you want, on the face of the bill, something that guarantees access to palliative care alongside, the access to assisted dying?
I think I would probably question whether or not that would be competent within the bill, but perhaps leaving that aside, I think what may be problematic in the assumption that palliative care is for everybody is that there would then almost be seen to be a requirement that one needs to go through and exhaust palliative care options before one has the right to the choice of an assisted death. I think, as I said earlier, I think what we see is internationally very much that those who are accessing this choice are overwhelmingly either in receipt or have been in receipt of palliative care. I think also what the committee heard from the witnesses in Australia was that as a result of introducing the legislation around assisted dying, what had been seen was, in a number of cases, an uplift, a significant uplift in investment in palliative care, hopefully addressing some of the issues around access. But also, I thought, perhaps even more interestingly, was an improved engagement with palliative care. I think that was a very clear message from one of the witnesses, reflecting the fact that the discussions that need to take place about the reasons why an individual is making the request, and then the discussion that needs to take place around the options that are available, is leading to people either having a raised awareness of what palliative care options are available, in a way that is perhaps not happening at the moment. I would expect that to be the case in this instance. As I say, I think it would be problematic, and I've been very supportive of the attempts by your colleague Miles Bigg to bring forward a bill around the right to palliative care. I think that has been an important campaign, and one I've strongly supported. But as I say, I think it would be problematic in the same way as it's problematic to say that you're not able to access palliative options until you've exhausted all treatment options, curative treatment options. So I think we need to, in a sense, put in place something that is competent, that improves the access to palliative care through the debate that this has opened up, and the pressure it builds to invest more in palliative care. But I think it would be problematic to put an amendment of the kind you're suggesting, Mr Whittle, on the face of the bill.
Yeah, I think that the situation that has been raised and is concerning is that you're absolutely right that palliative care is not for everybody, and the fact that you don't access palliative care shouldn't, if the bill passes, shouldn't prevent you from accessing. I 100% understand where you're coming from with that. I think the concern would be is if you seek palliative care and it's not accessible, then the pressure becomes more towards assisted dying. I think that's the concern, and what I want to ask God, number one, should somebody who speaks to the GP and requests more information or to start the process of assisted dying, should a GP discuss at that point the options of palliative care, and what happens if that's not available?
So, as I say, all treatment and care options need to be discussed. In order for this to be an informed decision, there needs to be an understanding of the rationale, the reasons behind the individual coming to the decision, the choice that they have. But it needs to be an informed decision, and it can only be an informed decision where there is an understanding of the various options that are available. I think that wouldn't stop at palliative care. It will be social care. It will be other factors that play on the lived experience of the individual. I think through the process I'm putting in place, as I say, those discussions are happening, provide safeguards that aren't there at present, where an individual is felt to have care needs that are not being met. If they are making a request of this nature, I'm fairly sure that the coordinating medical professional is going to go to some lengths to ensure that those issues are addressed. So in a sense, the safeguards that are being put in place through my bill are ones that don't exist at the moment. I suppose I go back to the point that in not passing this legislation, there is a risk that the status quo continues to have outcomes that are not ones that we as a society should be accepting. So I'm not, as I say, I'm not sure that, as I say, the amendment that you're suggesting might come forward to the bill is one that would probably be competent in the context of the bill. But I think is better addressed by the requirement under Section 7 of the bill I've introduced, requiring those care options to be discussed and steps taken where medics feel that other support is necessary and can be put in place. And that will change over time. And as I say, I mean, I think an original assessment of those options it may well be accurate, but over the period of the terminal illness, it may very well be that other options are deemed to be more appropriate that weren't necessarily considered at the outset.
Thank you for that. Can I move on to the topic of suicide and unassisted suicide? I think you know it seems to be from the evidence we've had. Some say that has a positive impact in terms of reducing the number of unassisted suicides, and others that it hasn't had an impact. I think one of the questions from a very practical sense here, and I wonder if you've discussed with insurance companies their take on this and whether an assisted dying would be deemed suicide and therefore potentially, you know, insurance policies becoming, unworkable or ineligible, or has that conversation been had?
Conversation was had. It was probably one of the first conversations I had, and the ABI have confirmed that it wouldn't be considered suicide. I think the issue around language is one that has been at the very centre of this debate, and there are those that seek to, in a sense, draw parallels between assisted dying and suicide. And I think I would want to reflect on a statement issued recently by a number of Australian organisations involved in suicide prevention, who state, "We are concerned that suicide has been confused with voluntary assisted dying. The two are very distinct, and using the terms interchangeably can be damaging. Suicide is when a person tragically and intentionally ends their own life. Voluntary assisted dying is not a choice between life and death. It is an end-of-life choice available to eligible terminally ill people who are already dying. It offers an element of control and comfort over how they die when death becomes inevitable and imminent. Both suicide prevention and voluntary assisted dying are as important as they are distinct. Confusing these terms can delay access to suicide prevention services for people in distress and complicate care for those who are at the end of life." So I think it's certainly the case that we know, and I think you were pursuing this with previous witnesses, Mr Whittle, the numbers of the suicide rate amongst those with terminally ill people across the UK is around 2.5 times the number for the population at large. So we can't know the details in every instance, but it does tend to suggest that, as I say, in the absence of a choice and the option, which is reflected in my bill, there are very many people who are taking matters into their own hands. And for others who have the financial wherewithal and have the physical capacity to access services of Dignitas in Switzerland, they are doing so. And they are doing so probably weeks, maybe even months ahead of time, in order to ensure that they have the physical capacity. But even then, those individuals aren't able to seek the support of medical professionals and possibly even family members for fear of the risk of prosecution. So I understand why there is a concern around this sort of normalising an approach to death. But these are people who are dying anyway. This is about the choice, dignity and control over the time and means of death, rather than suicide, which is a very different issue that needs to be tackled very differently.
I think you very much highlight the issue around those with a terminal diagnosis. There's inevitably going to be some impact on mental health. And as you say, that the suicide rate among that cohort is about 2.5 times the norm. So I think, again, I'm going to push on this one. It's having access to other services, or the lack of access to other services. You know, are you concerned that that lack of access to other services is inevitably leading down or would inevitably lead down a path
I don't think so. I mean, as I say, I think what my proposals do is put in place a heavily safeguarded, very transparent process whereby the individual who makes the request is supported to understand the options that are available. That medics are identifying where there are needs and where those needs are not being met. And that is happening in a way that simply isn't the case at the moment, and that those individuals are being left entirely to their own devices, often alone, and making horrendous choices and decisions for themselves that not only further traumatise them, but, as we know, traumatise those that they ultimately leave behind. And so there are gaps in services, whether it's palliative care, whether it's mental health services, whether it's broader health and care. There are certainly gaps there. But as I say, what these proposals do is put in place a robustly safeguarded process that means anybody coming forward to make this request has the reassurance of knowing that those wider needs, that context in which the choice they are seeking to exercise is kind of tested to the nth degree, and therefore I think can bring a degree of further reassurance and safeguard to things that are happening at the moment. I mean, even things like double effect and palliative sedation and all the rest of it, those are decisions that are being taken by medics, I think sometimes placing them in a fairly invidious position, and often without the input of the patient, sometimes without even the input of family members. And therefore, I think there's an opportunity here to provide not just the robust safeguards, but actually a degree of transparency around this, which is to the benefit of patients, but also to the benefit of medical practitioners as well.
Thank you.
Can I invite Dr. Ward just to add to that? Sorry.
Just around the issue with mental health issues, and we've heard in the committee as well that depression is also present in people who are terminally ill. This committee heard from Professor Colin Mackay in an earlier session, and he is a professor of mental health and capacity law. And he referred to a study amongst terminally ill people in Oregon and the Netherlands where depression was prevalent at a rate of between 8 and 47%. However, the number of people who went on to have an assisted death was only between 2 and 17%. And the study shows, and the professor himself said, that shows that the screening works in the assisted dying process. So I would just point to that, and also if the committee could have a look at the mental health charity SANE, who had written to the Westminster Committee, that might be a useful reference point as well.
Thank you.
Emma Harper.
Thanks, conveners. Just a quick question regarding palliative care versus the choice of assisted dying. We know that we've heard evidence from other countries that even though someone maybe has opted to go through a process of assisted dying, they might still then say, no, I won't proceed, and then continue with knowing that they can choose that, but continue with a palliative care process. Is that what your experience is in researching for this?
I think you make an entirely valid point, Ms Harper. I mean, pretty consistently across the board, around a third of those that apply for an assisted death in jurisdictions with a terminal illness mental capacity model, about a third of them don't end up taking them. And I think it's fairly safe to assume in the main that is because they find that the palliative or other care that they're in receipt of meets their needs all the way through to death, and that what I suppose it was implicit in the quote I gave from the woman with MND, that it's the insurance policy of knowing that if things get too much, that option of an assisted death is available. And that in itself, I think, has a palliative benefit. I mean, it provides a degree of reassurance. It allows the individual to get on with living their life, making the most of whatever time is left available to them, whether that's measured in years or months or days. the fear of what is to come, I think, cannot be underestimated as one of the worst aspects, whatever the physical aspects, that the existential suffering that those at the end of life go through. Pain management, as you will know better than I, Ms Harper, is pretty sophisticated. You can manage a lot of the pain. I've certainly heard from physicians in Australia who indicate that very rarely are they dealing with issues of pain. It is the existential suffering that is leading individuals to opt for an assisted death. But I think the fact that you've got such a high number of people who are making the choice but then not going through with it is, I think, an indication of why it's being chosen. And the benefits that come with simply having that kind of insurance policy there in the background.
Thank you.
David Torrance.
Thank you, Convener. Good morning, Liam MacArthur, and to the witnesses. Mine is around the act of assisted dying and the means of death and the substance used. Some of the respondents to the committee have raised concerns about complications in assisted dying, and this site, Oregon, is where evidence indicates that 7 to 11% people have complications in assisted dying, from vomiting to waking up, prolonged deaths, whereas on the other hand, the committee has heard evidence from Australia and Canada of minor complications where they can get intravenous drips in, but nothing of major. How would you address that?
I think the evidence the committee heard from Australia was, I think, very telling. I think there really hasn't been examples of problems. I mean, I think it's worth pointing out, and the medics on the committee will understand this far better than I, but the act of dying can involve quite distressing implications for the patient and implications for those family members or whatever who may be supporting them. So I think we need to be cognizant of that in understanding how an assisted death would work. But I think the evidence from the witnesses in Australia was very telling. I think there are certainly reasons historically in the US for why there may have been issues arising, certainly in the early stages, around sort of regulation of medications and what could be used and the access to those medications. Those, as far as I can see now, appear to have been addressed, and as I say, the more relevant evidence in more recent years comes from Australia, where, as I say, there do not appear to be any problems. I don't know whether Dr. Ward wants to add to that.
Yeah, just to give the committee assurances that we've had extensive engagement with pharmaceutical colleagues and stakeholders. And just this morning, I was helping the Royal College of Pharmacists, who you heard from, Community Pharmacy Scotland, and others, have a meeting with Professor Michael Dooley, who was the person that many of the state governments in Australia tasked with finding a protocol that worked 100%, and they are now going to meet with him to have the discussion around the medication and in particular the self-administration aspect and how that is borne out other than just swallowing. So just to give assurances that although there are sensitivities around discussing the medication and the pharmaceutical aspects, it's certainly something that we've explored in detail. And as Liam said, there were issues, 20 years ago in Oregon when this is new and emerging, but we now have a very refined protocol that, as Liam said, we know works at 100% effectiveness.
Around assistance, Section 15 of the bill describes assistance as providing a substance to end a person's life, staying with an adult until they have decided they wish to use the substance, or removing the substance if they decide they do not wish to use it. Whereas in the UK bill, it contains more detail, and it goes on to say, prepare a substance for self-administration by a person, prepare a medical device which will enable that person to self-administer the substance, and assist that person to ingest or otherwise self-administrate the substance. And we've heard the concerns raised by M&D Scotland. So why does the current bill not specify or define what actions would be considered to constitute self-administration?
Yeah, and I was interested in those exchanges. Obviously, I think it's is probably one, going back to Ms Mochan's earlier questions, which may well fall more appropriately into guidance. But the self-administration element, as I say, is an integral part of this. I think it's worth reflecting probably the difference, not so much between the bill I've introduced and the bill being considered by Westminster, but in other jurisdictions with similar legislation, that very often the medication is dispatched to the patient, and the medical professional is not present at the point the medication is delivered. So I mean, I'm happy to look at whether or not there's kind of further refinement of that is necessary. I think it is an important safeguard that the medic is there, not least, I think, to ensure that final assessment of capacity and intent is made. I think there's a feeling that an individual may wish in their final moments to have a degree of privacy. How you manage that while ensuring the safeguards is probably a question to reflect on further. But yeah, I mean, I think, as I say, I think the safeguard that's in the bill seems to me to be one that is robust, and, as I say, is absent from other jurisdictions where it doesn't seem to be a problem. But that's for them to justify rather than me.
Must stay with a person until they're died, but not in the same room. And as you were there at the evidence session, Police Scotland questioned basically how a health professional could assure that no third-party involvement was taking place.
Yeah, I mean, I think given all the process that goes before that, I think there is, a fairly high degree of reassurance about intent, whether there's any coercion, which would obviously bring the process to a halt. So I think those safeguards need to be seen as being relevant to the point at which the medication is delivered and the assessment of intent and capacity is made. So I was interested to hear the concerns. I'm not necessarily sure, as I say, if it is the patient's wish for a degree of privacy and discretion at the end, is that something that we would wish to see denied? But I think if there are sort of further clarifications in the bill that might be helpful in this regard, then I'm kind of happy to look at those. I don't know whether Dr. Ward wants to add anything.
No, just to point out, I now live in Queensland, Australia, and there are many jurisdictions throughout the world that, as Liam said, the medication is sent in the post, and that is then the decision, the person's decision as to who is there, the time, the place of their choosing. The previous bills I was involved with as well, with Margot MacDonald and Patrick Harvey, we didn't have a healthcare practitioner at the death, so that's an additional safeguard that we've added in. Just quickly with your previous question, David, around why we don't have the detail about how much assistance can be given. My understanding is that that's because the law in England and Wales is different. They have the Suicide Act of 1961, which specifically prohibits assistance in dying. We don't have that in Scotland, so there's a distinction in the existing law there.
As we've only reached round about the halfway point of our questioning, I'm going to suspend briefly for a comfort break. Welcome back to this session. We will continue taking evidence from Liam MacArthur and his accompanying witnesses. And before I start, I would like to remind members of my register of interests. I am employed as a bank nurse by NHS Greater Glasgow and Clyde. I'd like to explore a couple of issues with you, Mr MacArthur, initially starting off with conscientious objection. And we've heard various arguments and questions at committee in relation to the conscientious objection clause in the bill, and who that includes and what the clause extends to. Now, section 18(1) of the bill does not sets out that no one is under any duty to participate in anything authorised under the bill if they have a conscientious objection to doing so, and the bill does not prescribe who the conscientious objection would apply to, but the policy memorandum indicates that it's intended to apply to doctors and other healthcare professionals in the process. Now, I think there's some argument that the clause replicates a provision in the Abortion Act 1967 and is therefore likely to be interpreted in the same way by the courts. That would mean that the objection clause may only extend to those directly involved in the process, that's assessing, prescribing and providing assistance. So could you perhaps clarify your thinking round about that and who you envisage that that conscious objection clause would apply to?
Yes, thanks, Convener. As you've described it, it would be my expectation that it is those who would be directly involved in the process. I think that's a proportionate approach to take to the conscientious objection. I think it would maybe be a degree of caution needs to be exercised in drawing parallels between the process described here and abortion legislation, but I think the way in which the conscientious objection works is one that I would see being appropriate in the context of assisted dying. There are obviously others who may be at some stage removed from the process. I think one of the examples that was given to me was others in a hospital or a hospice setting who are aware that other colleagues are engaged in assisting somebody at the end of life through the proposals in my bill, and may have an objection to it. I think it's problematic extending that conscientious objection too extensively. I think it is about choice, but choice for those actively participating in the process. And I think extending it more widely runs the risk of putting up I think unnecessary and unjustified barriers to individual patients who meet all the eligibility criteria being denied access to that choice.
So it sounds like what you're proposing would be something that would be quite discreet in terms of that conscientious objection. How do you then counter some of the surveys that have been done with palliative care staff, for example, staff who work in hospices, who have, according to surveys, quite large numbers of those have thought or talked about leaving those services should your bill be passed?
I mean, I've been interested in those. I mean, obviously, going back to the earlier response I gave in terms of the numbers that are likely to be involved in the process, as we see from other jurisdictions with similar models, it is a relatively low number, and to some extent a lower number still in terms of the first and second year. Over time, those numbers are likely to increase. I spoke at the Hospice UK conference at the end of last year in Glasgow, and it was clear to me from the exchanges there that there is a considerable amount of discussion and debate within the palliative care sector. I think there are certainly those who have very strong opinions and in opposition to a change in the law. There are similarly those who are strongly in favour of it. I think a great many have questions, simply want to know how will this impact on the care that they deliver to their patients. As I said to them, I think introducing the choice of an assisted death as one of a range of end-of-life choices allows them to do what they do well, which is meet the needs and limit the suffering of those that they are supporting. So I think attitudes to legislation before it is in place often change and can change quite dramatically after the legislation is introduced, with a clearer understanding of what the implications may be. I don't really see any reason why the situation here in Scotland would be any different from other states in Australia and the US, where practitioners have engaged and as I said earlier, often find this one of the most rewarding things they're able to do, to give their patient, those they're supporting, a good death. That seems to be at the heart of what palliative care is about. So I've heard the concerns. I've tried to do my best to engage with the sector to try and provide a degree of reassurance. I mean, obviously the bill, as well as the conscientious objection, does not compel anybody to engage with it. But I'm confident that there will be sufficient doctors to help support it. And those numbers, as I say, are likely to increase over time as understanding and confidence increases and as the training is rolled out to practitioners.
So can I raise then an issue that was raised with me last week by a group of GPs in my own constituency? And it was a question I wasn't able to answer. So perhaps you can give me a definitive answer. So they were asking if they conscientiously objected, or their colleagues did, would there be a duty for someone expressing that conscientious objection to refer a person requesting assisted dying to another assessor?
There would be, I think, an expectation, as there is with an abortion, with the way in which the conscientious objection works for abortion, for the medical professional to refer the patient on to somebody that can provide support. And I think that is an important principle within delivery of health and care services. I think it protects that choice on the part of the practitioner, but doesn't put up unreasonable barriers to individuals accessing the choice that they should have as patients to get the support, the treatment that they feel that they need.
So the status of assisted dying as a reasonable treatment option in Scotland is unclear, and there have been calls for this to be directly addressed in the bill. If assisted dying is considered to be a reasonable treatment option, then doctors would have a duty to discuss it with patients in appropriate situations, regardless of any conscientious objection they may have in practice. So how would you respond to that?
Well, I think the bill and the supporting documents are clear that the process is initiated by a request on the part of the patient for an assisted death, at which point, as I say, the requirement on the medical and the coordinating medical professional is to ensure that they understand the rationale, as I say, for arriving at that decision, but equally to ensure that the individual is aware of all of the treatment options, care options that are available. I think what's very difficult, and in listening to the evidence that you've heard over recent weeks, I recognise there's as much as one would like definitive clarity, proscribing or prescribing what it is that a medical professional can and cannot discuss with their patient is territory into which I think we as parliamentarians probably need to tread very, very carefully. So, as I say, I think the expectation is that this is a process that's initiated by the patient making the request, and thereafter the process and the safeguards that we've taken time to discuss this morning would then kick in.
Thank you for that. One of the other areas that the committee touched on was qualifications, and I believe in the bill it speaks about medical practitioners. I might be slightly misquoting there, but the clarity that we got from witnesses was that the level of qualification required for doctors to be able to participate in assisted dying could encompass those at FY2 level, so foundation year 2 level. We asked the Royal College of Psychiatrists when they were here at committee about their level of confidence in, as junior a doctor, participating in those assessments of capacity, etc. And they were quite resolute in their answer that they didn't feel that they had sufficient experience at that level of their training. So can I ask why you've chosen that particular term, which does encompass such junior doctors, and whether, should the bill pass at stage 1, that would be something that you would look to amend?
I think the evidence on this was very interesting. I mean, I think it's also fair to say that the BMA, the Royal College of GPs, seem to be fairly relaxed about the way in which this was expressed. I think recognising that this is an element of the bill where the detail is probably more appropriately set out in secondary legislation and in guidance. I think in order to undertake the work involved in providing support to patients around assisted dying, there would be requisite training required. And again, we've touched on some of this earlier. So I think, as things stand, I think the bill probably goes as far as it can in expressing who is likely to be involved in this process. But I think there is an opportunity, and certainly my expectation would be that government, along with the professional bodies, would work to identify how best to express this through secondary legislation and through guidance.
Thank you. Emma Harper.
Thanks, Convener. It's just to pick up on the duty to refer. If I'm a carer looking after somebody at the end of their life in their home, and I am a conscientious objector, and the person who I'm looking after at the end of their life says, OK, that's it, I'm done, I want to go down the assisted dying pathway. And how do we then help support the conscientious objector who's a carer, refer on, or do they just keep their mouth shut, or do we require them to refer? And then would that be then part of secondary guidance education legislation in order to just basically require them to refer, because this is about the human rights of choice at the end of it?
Yeah, again, probably one that would be more appropriately picked up in the guidance. I mean, whether or not there'd be an expectation that somebody in that position would refer the individual to their GP to seek support. I mean, that would seem to be the most logical option in those circumstances. But it seems to me that that's something that's going to be difficult to express on the face of the bill, and would be better coming through in terms of probably less secondary legislation, more in terms of guidance. I mean, as I mentioned earlier, I think there'll be training requirements for those directly involved, but I think there'll be a wider training requirement just in terms of raising awareness amongst those involved in health and care more generally about what the change in the law means, and whether or not they have a conscientious objection. I think it would be in their interest to understand what those implications are. But as I say, that would probably be better expressed in guidance rather than through the bill.
Okay, thanks.
Gillian Mackay.
Thanks, Convener. Section 22 of the bill precludes provisions relating to reserved matters, which has raised concerns about Scottish Ministers' ability to designate an approved substance for assisted dying. Because this designation is critical for the bill's practical implementation, and I appreciate what Mr MacArthur said earlier about not everything needing to be on the face of the bill, but the practical implications are obviously of interest to the committee. What steps or negotiations are being considered with the UK Government to resolve that particular issue? And how could it provide, if it could provide any delay, how could that be managed in the interim?
Yeah, I mean, it was helpful to an extent. Maybe didn't feel it at the time, hearing from the Cabinet Secretary last week. I mean, I've always been clear that while the presiding officer has given the bill, or deemed the bill to have sort of legislative competence in the context of the powers of the Scottish Parliament, I've always acknowledged that in order to put in place a fully functioning process of assisted dying in Scotland, it will require issues that are the preserve of Westminster to be addressed, and particularly, as you say, Ms Mackay, in relation to Medicines Misuse of Drugs Act, etc. But as the committee heard on numerous occasions last week from Mr Gray, those can only be, I think, resolved at the point at which the Scottish Parliament decides whether or not it believes a change in the law is required. So I don't think I'm breaching any confidences to say that I've had early and occasional discussions with UK Government as well as Scottish Government, just to keep them updated really on the process of the bill that I think I first announced I was planning to introduce it back in June 2021. So keeping people up to date with what was going on in the background and reassuring them that it was going to emerge at some stage has been important. But those discussions have taken place in the context of a recognition on both sides that both the UK Government and the Scottish Government have quite understandably and justifiably, I think, taken a position of neutrality on this, are awaiting the outcome of the Stage 1 vote on this, at which point the mechanisms that can address those issues of legislative competence can be addressed, and I'm confident that that can happen in a timely fashion.
Another issue in the sort of same vein, the bill grants ministers power to set qualifications for participating doctors and requires them to take account of a second opinion. However, it's the case that some of these aspects may also be affected by reserved matters, such as the regulation of health professionals. What deliberations have you had on that matter in particular? And Dr Ward might have some contribution on that as well. And what collaborative processes do you envisage, and what prospects are there for securing the necessary consents from the UK Government? And what overlap is there in that provision in particular between the bill here and the bill within the UK Parliament?
Yeah, I suppose the other one that gains a little less attention than the medication and its interaction with sort of UK responsibilities is the one around regulation of professional bodies. But similarly, that would need to be addressed in order for the fully functioning process of assisted dying to be put in place. That's not to say that the bill as it stands isn't competent and cannot go through the full scrutiny process and be passed by this Parliament. But I think I kind of understand why this committee and MSPs more generally, as well as the wider public and those with an interest in it, will be keen to have a clear understanding of how those powers are to be exercised, and us a confidence, or give us a confidence in how this will work in practice. And in terms of the specifics of the regulation of professional bodies, I don't know whether Dr Ward, there's anything else you want to add?
We set out in the accompanying documents the processes that we would and have explored to make this fully competent post positive vote at Stage 1, but I'd maybe hand over to my colleague Claudia on this one.
I'm not sure what to add to what Mr Mackay has already said. I mean, very careful consideration was given when we instructed and drafted the bill to the way in which the framework for assisted dying could be devised within the limits of the Scotland Act. The member has given evidence here explaining the policy on which his legislative competence statement is based as well, and yeah, he's been clear from the start that there might be some issues around implication, and he's given some suggestions in the policy memorandum of the possible ways in which that could be resolved. But it's obviously up now to the two governments and the member to discuss that further.
I think it's worth. This is a sensitive issue that needs careful and sensitive handling. I was very conscious from the outset that what I didn't want to do was use it as a mechanism to kind of push the boundaries of constitutional arrangements, and so have operated as Ms Bennett's just articulated within that framework. But I'm very confident that the mechanisms exist to resolve those issues. And I think, given what we're seeing at Westminster with a very similar bill going through that Parliament, coincidentally with the bill we're considering this morning, I think that perhaps enhances the opportunities for making sure that this is an area where relatively speedy progress can be made once Parliament decides whether or not it's supportive of the general principles and supportive of a change in the law.
That's great. Thanks, Convener.
Sandesh Gohani.
Thank you. I'd like to turn to ask about death certification and how a health professional would go about filling that in. So we don't want to skew death stats. If somebody has a terminal lung cancer, for example, it's very important that that is captured in the data. So what's the thought process that's gone behind the way that you would like us to fill in the forms?
Well, I think as you'll be aware, Dr Gohani, in the schedules to the bill are effectively the forms for this and other aspects of the kind of reporting requirements under the bill. I think it would be important that those reflect the underlying progressive advanced terminal illness that had given rise to the application, and for that to be captured. But similarly, I think the fact that medication being administered to allow for the assisted death. Now, I had initial discussions with the Chief Medical Officer around this. I think recognising that there is a legitimate concern about the expression of this that may kind of suggest, and this back to the earlier point, of the distinction between suicide and assisted dying, that there may be some sensitivity around that. But I think for the purposes of clarity and transparency, I think both of those need to be captured, and both of those in the schedules of the bill are captured. But the Chief Medical Officer and his colleagues helpfully suggested that there are codes that are used for those registrations that may allow for that information to be captured, but captured in a way that I think respects and acknowledges the sensitivity around what we're discussing here this morning. So that's something I'm kind of keen to explore further, but I think it is important that we understand who's accessing the option of assisted death, what are the conditions, when are they accessing it, the sort of socio-demographic that is accessing as much information as possible, anonymised of course. But as we might come on to touch on later, that reporting and understanding of the picture of how it is working in practice here in Scotland will be crucial for those annual reports, but then feeding into that 5-year review that is also set out in the bill. If you look at other jurisdictions, there's a lot of similarity in terms of who's accessing it, when they're accessing, the reasons they're accessing, and the kind of demographic profile. But it's absolutely essential to my mind. In fact, that was the only element of my proposals that changed between the initial consultation and when I brought forward the bill, was tightening up the data reporting requirements of what would be envisaged in the proposals. Because I think for public confidence, for the confidence of patients and indeed of medics, the more robust those requirements are, the better.
Certainly, we will come on to the reporting aspect. But just to go back onto the death certificate itself, it is vital that both are captured. But it just seems to me that 1A, which is the way that somebody has actually died, should be the big terminal illness that person has had, with assisted dying perhaps being in part 2. So both are captured, but we don't lose sight of the terminal illness itself.
That would certainly be my view. I am conscious that there are others who take a different view on this. I think there is a way of ensuring that the information that needs to be captured is appropriately captured. And as I say, I was reassured to some extent in my discussions with the CMO and his colleagues that there's a way of navigating this that, as I say, is done sensitively but makes absolutely sure that the relevant information is available so that we have the understanding we need to have about how this is working in practice.
And moving on to reporting, are you happy that we have enough here in the bill to be able to robustly look at what has happened over each year, and then that feeds into the 5-year review? If you do think that is the case, what learnings have you taken from other jurisdictions that already do reporting? Because let's not reinvent the wheel.
Yeah, I mean, as I said before, the numbers likely to be taking up the option of assisted death in the initial years is likely to be fairly low. That's certainly the pattern we've seen in other jurisdictions. So the information we have on who's accessing it and when and how, etc., will then be more limited than one would expect in later years. But it's important we capture this from the get-go, so the annual reporting requirements kick in year one. So there will be an understanding by government relevant bodies, by this Parliament, what is happening. I know there's been some concerns expressed as to whether or not a 5-year review is too far down the line, that some maybe argue that a 3-year review may be more appropriate. I think there's a balance to be struck here. I can understand why there may be a desire to absolutely make sure that any changes that might be needed can be taken account of as quickly as possible. But if you don't have a sort of detailed data set to draw on, you're going to find it more difficult to make an informed decision. We'll have a more difficult decision to take as parliamentarians, informed by those in the field, about how the legislation working and whether and where amendments might be required. So I think a 5-year review seems to me to strike that right balance, to give you the data set while ensuring that there is an annual reporting system in place that can pick up things in real time.
There might be any additional information that we need to have on the reporting that might be able to provide additional safeguards or reassurance?
There's an option for Scottish Government to add in additional requirements in terms of the data gathered. I think what I've sought to set out is the data that, on the face of it, looks the most relevant, certainly reflects what the data gathering processes look in other jurisdictions. But if there are other elements that government or stakeholders informing government feel need to be added, there's a mechanism for doing that. I suppose that, as with any data gathering, there needs to be an understanding of why is it that this is being added to the list. I mean, these are processes that are not without time implications, cost implications, and all the rest of it. I think so. You need to understand why it is you're gathering the data and to what end, what purpose. But it needs to be as comprehensive as it can be, as I say, in order to give the clearest possible picture of how the legislation is working in practice, and to inform any future decisions about how the legislation may need to be adapted.
Thank you.
Paul Sweeney.
Thank you, Convener, and thank you, Mr MacArthur, and colleagues for attending today. Just want to turn to last week's evidence session, where both Police Scotland and the Crown Office Procurator Fiscal Service did seem content that the current law and the bill would interact in a way which would not hinder prosecution in appropriate situations. I note that sections 19 and 20 of the bill, as presented, deal with criminal liability and a mirror provision for civil liabilities. Subsection 1 of Section 19 refers to it as not a crime to lawfully provide a terminal adult with assistance to end their own life. But then subsection 2 does not limit the circumstances in which a court can otherwise find that a person who has assisted another to end their own life has not committed an offence. I know the explanatory notes highlight that this would be in the context of complying with the provisions in the bill. Do you see there being a risk that there could be litigation or police complaints made, or the risk of this being tested by people who are disputing their relatives' competence, or other scenarios where this might end up being augmented by case law?
I think we've both been involved in politics long enough to know predicting what individuals will seek to legally challenge is very difficult. But I like you, I was, I think, reassured by the responses we heard from Crown Office, Fiscal Service and from Police Scotland in relation to those provisions of the bill. I think it's fair to say, I mean, we touched on coercion earlier on. Again, speaking to practitioners and those involved in the oversight of legislation in the likes of Australia and the US, they consistently argue that the greater concern is not coercion by family members of somebody into assisted dying, but rather difficulties that some family members may have with the decision that a relative has taken to opt for this choice. So I think that maybe does point to the concern that you're raising here. But it's why the safeguards, the procedures that are in place are as robust as they are. I think it is there to provide protection first and foremost for the individual, the patient themselves, but providing robust safeguards for medical practitioners operating in this area. And again, the phraseology in the bill we wrestled over in terms of the discussions taking place between the patient and family members is difficult to capture because families operate very differently. So requiring a discussion to take place with the family can be highly problematic in instances where family members may be estranged from each other or whatever. But clearly, in order to manage the process and manage the process of grieving after the death, the more discussion there is with whether it's family or that support network around an individual, the better. And that would certainly be the expectation. And the advice I would expect medical practitioners to be given to their patient. And I think the more those conversations are taking place, the more you minimise the risk of family members, for example, feeling that the process wasn't robust, or feeling blindsided even about the fact that this decision had been taken by a relative.
It'd be worth considering further detail on dispute resolution mechanisms where interested parties or family members or people with power of attorney, for example, may have a concern about coercion, for example.
I think what's interesting in looking at other jurisdictions is I suppose the landscape that grows up around legislation like this, and that there are many charities, third sector organisations that have been campaigning for a change in the law. And I think I've made very clear that they would expect to continue in providing help, support, advice to those who may be seeking to access assisted dying. But perhaps you can also provide the sort of support that you're talking about, Mr. Sweeney, which it may be rare, but I think where it exists and where there is a need, it would be good to think that need would be met. I mean, as I say, consistently, the feedback from those jurisdictions where assisted dying laws are introduced is that the process of coming to terms with a loved one's death and the grieving process thereafter is eased by knowing that that loved one has the choice, the control, the dignity, etc. At the end of life that at the moment is absent here in Scotland. For a small but not insignificant number of people. I mean, I think I need to keep reinforcing we're talking about this because this is the focus of the bill, but the vast majority of Scots will continue to not need an assisted death. They will be supported by palliative care, social care and other health and care services up to the point of death.
Okay. Just also wondered, in the context of conditions where the prognosis is hard to determine and there may well be a long period between someone making clear they want to undertake an assisted death, have made the relevant provisions in accordance with the provisions in the bill, but then there's a long period where there could be scope for further pressure being applied, or there could be other influences on the person's thinking. A lot of people might want to make provisions for it in the anticipation of some comfort, and maybe in palliative care, or whether going through a terminal illness where having the option to end their life on their terms may provide some comfort. It may not actually be used in the end, but perhaps that creates an open-ended period after those provisions are in place where lots of circumstances could change. Do you feel there could be more detail around that longer period where there could be intervals where that is reassessed by relevant professionals and an interested coordinating doctor, for example?
Yeah, I mean, I think the only relevant point at which a reassessment would be required would be at the point at which an individual seeks to act on the initial request that had been through the full process and the second declaration made, but there isn't a time restriction. That declaration remains valid. But at the point at which medication might be provided, as I said earlier, there would be a requirement for capacity and intent still to be established. So if there had been any change in that, then that would prevent the kind of process proceeding. But I think it's important, for the reasons I think discussing with Ms Harper earlier, that people may choose at different stages. I mean, some may have the relative luxury of going through this process sort of relatively early on, providing that degree of comfort and reassurance. There are others whose diagnosis may come far closer to the point of death and who are needing to act with greater speed, so to speak, need to get things in order in a shorter time frame. But as I say, I think the point at which the medication is provided would be the point at which capacity and intent would be established. Those individuals, though, with a terminal illness will be receiving their support, whether it's from the GP, from a consultant on an ongoing basis. I mean, they will be almost certainly in receipt of ongoing treatment or palliative care. So those discussions will be ongoing. So I find it difficult to imagine a situation where that is not arising in the background. But I suspect the focus will be very much still on what are the kind of treatment and palliative options that are available, which may change over time. I think the committee's heard this on numerous occasions. It's not just the prognosis period that's difficult, but actually the way in which the terminal illness develops over a period can be difficult to predict. So those discussions will need to be continuing on an ongoing basis.
It's very hard to balance risks, and there's risks in any scenario, and human behaviour and human situations are obviously very complex and varied. The provision does make it clear there's an offence if someone is coerced into making a first or second declaration. I just wonder whether an influence on a person's thinking about whether to undertake an assisted death might be the lack of provision of other alternative medical treatment, such as palliative care, and that could in fact the denial of that timely treatment act as a coercive influence on the person's thinking. Do you feel that could potentially introduce a legal dispute about access to alternative treatments, and that maybe family members might consider that denial of alternative treatments being the stimulus for the person undertaking the assisted death can itself present a criminal case?
I mean, I think this goes back to some of the issues that Mr Whittle was raising earlier. I mean, I think those discussions around what the options are exposes them and allows an opportunity for those to be addressed. And I think it reflects what the committee heard from witnesses in Australia, that actually the engagement, the quality of the engagement, the level of engagement with palliative care has gone up since the introduction of assisted dying, not just because of, I think, the additional investment that's gone in, but because of those conversations either flagging an awareness or raising an awareness, but actually, in a sense, requiring a discussion and an active engagement around what those options are and how they might apply. So Look, as I said in response to your initial question, Mr Sweeney, there's probably no way of preventing an individual bringing a legal challenge, but I think the measures, the mechanisms that are in the bill provide, I think, a very high level of protection against those sorts of cases arising. And as I say, it invariably it tends to come from a difficulty that some family members can have with the fact that the relative has taken this decision. I mean, conscientious objection exists in medical profession, and we can put that in the bill. What we can't put in the bill is kind of protections for family members who are implacably opposed to this option, and therefore may have difficulties with a family member opting to go down this route.
And in terms of this so-called phenomenon of doctor shopping, which other jurisdictions have mentioned, particularly Canada, where if there's clinicians who aren't willing to participate, it inevitably nudges someone who is persistent in their desire towards those clinicians who would be minded to accept. Is that an inevitable risk of coercion, just in the fact that someone is then accessing a cohort of clinicians who are minded to be supportive of their position, even if other clinicians have concerns?
Yeah, I mean, I'm minded to reflect on the advice of the chief medical officers across the UK about those engaging in this debate, praying in aid, patient experience from other jurisdictions, without the consent of that patient and without necessarily the full facts of what happened. I think what you have in the bill here are pretty robust protections about how the request is made, then the assessments that are made, and where eligibility criteria isn't met, then the process ceases. It would still be open to a patient who had been deemed ineligible to access this, to go to another medic seeking another opinion, but it's not immediately obvious why another medic would automatically come to a different opinion on this. And actually what we're seeing is examples in other jurisdictions where those who are not eligible doesn't stop them making an application, but the safeguards do what they're supposed to do, which is prevent them accessing the services available. And whether that's around them not having capacity or their terminal illness not meeting the requirements under the legislation. But the safeguards there don't stop somebody making the application, but they should stop them then being able to proceed with it. I mean, as I say, we trust our medical professionals to make many life-altering, even life-ending decisions. We ensure they've got the training to make the decisions they need to do around that. And in this instance, we require a second medical practitioner to make assessments as well. So it's more, I mean, ultimately, if this were put in place, this would be the most heavily safeguarded end-of-life choice option available, I would say.
There are a lot of potential provisions in Section 23 around guidance, and Scottish ministers can undertake secondary legislation to detail a lot of that. Do you think there might be some instances where it would be preferable around this sort of area of coercion to have that more on the face of the bill and relying on ministers to augment the legislation?
I definitely have that kind of poacher turn gamekeeper kind of feeling at the moment, as I've sat where you have on many occasions, Mr Sweeney, and made precisely that argument, usually to government ministers, about the importance of putting certain things on the face of the bill. I think the balance needs to be struck. I mean, as I said in answer to earlier questions, I absolutely understand the desire to have as much clarity as possible about how this works. I don't think it's the interest of anybody to put things on the face of the bill that ultimately then require primarily legislation to emerge as to change as emerging evidence and whatnot suggests that they should. But in a sense, that's why through the explanatory notes and through the policy memorandum, I've try to flesh this out as best I can. I think a lot of this does more appropriately sit within either secondary legislation or, as I was saying earlier, in relation to guidance, because that allows, I think, the understanding of medicine, which is developing at a pace, to be factored in terms of the way that this legislation would operate in practice.
Thank you, Kieran.
Sanjit Gohani.
Thank you, Convener. I just want to turn again to coercion, but a slightly different angle. I was very concerned by the evidence given by Police Scotland about coercion, and I'd just like to give you an example. 2 doctors have signed saying that this person can go ahead with the assisted death that they have chosen, and the person goes ahead. Later on, a family member, for whatever reason, decides to challenge that and say, well, there was coercion going on and other things. The police have said that there does not seem to be enough robustness around the process that the medics would follow to say there has been no coercion. And potentially, the medics would be liable to be in trouble with the law if it was subsequently found that there was coercion despite their best efforts. So is there a way that we could tighten up coercion around this topic?
I mean, I was intrigued by that. I mean, to some extent, it would beg the question, do Police Scotland have the same concerns around double effect, palliative sedation, withdrawal of treatment, and those other treatments that at the moment are legal? I think the proposal set out in my bill put in place, as I say, the most rigorous and robustly regulated end-of-life choice that there is. And the assessments around coercion, around capacity, are, I think, as robust as they can be, and are required not just of one but of 2 medical practitioners. So I think in response to that question, I would be interested to know whether, as I say, those same concerns are ones that Police Scotland have in relation to what is legal at present, but where there is equally scope for complaints to be made or legal challenges to be made, as compared to a system which I think is far more transparent, where the views of the patient are absolutely at the centre, and where there is any concern around that by either of the doctors, or where there's an onward referral to a specialist, that process then comes to a halt. I think that provides greater protection, not just, for, as I say, for the patient, but actually for medics who, as I said earlier, seem to me sometimes being put in a fairly invidious position in terms of the choices that they're having to make.
So is there scope in secondary legislation to have a discussion with Police Scotland to create a process that medics could follow to ensure that, and I think it's very important at this point to say there's a big difference between neglect and just outright not doing your job properly, and doing your best and it being found that there's subsequent differences. So would there be scope to have that discussion with Police Scotland, the Procurator Fiscal, to create a process that's robust enough to defend medics that actually use the process properly?
I mean, there's certainly, there's always value in having further conversations. I mean, I think the bill as it stands does provide those protections. I think what the committee also heard from the Crown Office last week was the kind of expectation that deaths that occur through the assisted dying process would be subject to kind of oversight by the Lord Advocate. Now, I know that the Crown Office was slightly kind of uncomfortable anticipating the view of the Lord Advocate, but I think that would be a reasonable expectation. And again, I think that provides a degree of reassurance there. I don't know whether any other colleagues want to.
Thank you. Yes, just in response to what Mr. Gohani was saying, it's just to point out that the in schedules to the bill, the declarations made by the medical professionals. They sign that, to the best of my knowledge, the person is making the request to be lawfully provided with assistance to end their own life voluntarily, and in particular have not been coerced or pressured by any other person into making it. So it's to the best of their knowledge at that point. And the only other point to make was to refer back to the actual offence. It's a person coercing the terminally ill adult into making either a first or second declaration is the specific nature of the offence. So it's just to draw your attention to those 2 points.
Okay, thank you.
Thank you. I just have a couple of questions in relation to court involvement. So the bill before the UK Parliament made provision for all assisted dying applications to be considered by the High Court for England and Wales. There was court involvement was seen as an additional protection by some of the respondents to the committee's call for views. So was this something that you considered?
I did, because I was aware that it had been an aspect, I think, of earlier bills that had come before Parliament in Westminster. I wasn't necessarily convinced that I could see what additional safeguard it put in place, and I think the balance always here is ensuring that the safeguards do what they're intended to do and don't simply act as an unnecessary obstacle that don't really provide any protection. And I think with that, I understand that the committee looking at the bill at Westminster is likely to consider an amendment to remove that provision. It remains to be seen whether that happens. But I think I drew again a bit of reassurance, as I said to Dr Gulhani there, from what the Crown Office were saying in relation to Lord Advocate's oversight of deaths under assisted dying, where I think that maybe offers the sort of reassurance that the public might have expected the court oversight to provide. Yes, well, as I say, it remains to be seen whether or not it remains a part of the UK bill. But I'm not convinced of the arguments of introducing that here would add anything other than a delay to the process for those that meet all the eligibility criteria.
So it was also noted by several respondents that there's no provision for challenging or reviewing decisions made by doctors. So whether someone meets the requirements of terminal illness as defined in the bill, whether they have capacity to make that decision, and whether someone has been coerced. And the Edinburgh Napier University Centre for Mental Health Practice Policy and Law Research submitted that they were concerned at the lack of any accessible mechanism by which the decision of a doctor can be appealed or independently reviewed by the courts. Again, is this something that you considered, or is it something that now, looking at the bill, that it's been under some scrutiny, something that you would consider amending?
I mean, I think the fact that you've got two practitioners acting independently of each other, making the assessment both around terminal illness and around capacity, that have the option where it's felt to be necessary to refer to a specialist, either in relation to the terminal illness and or in relation to capacity. I think those are safeguards that go well beyond the safeguards that are in place for many, if not all, other treatment that is available to patients. I mean, ultimately, whether or not we would agree with the choice that an individual makes, if they meet the eligibility criteria, I think it would be unreasonable to deny them the opportunity to make that choice and activate the provisions as set out in the bill. So,
is it then unreasonable for there not to be an appeal process for someone who perhaps has been denied access to assisted dying?
What do you mean? So almost the other way. I suppose the safeguard is that you need to be able to satisfy, or two medics need to be satisfied that you meet the eligibility criteria of an advanced progressive terminal illness and having the capacity to make this decision. The other safeguards we've covered off. If you don't meet those to the satisfaction of both the medics, the option remains open to you, and we discussed that earlier, to go to another medical practitioner, but it's difficult to see how necessarily you would satisfy them and a second medical practitioner that you met the criteria. So there is the option for an individual to seek to get a diagnosis, but medical professionals are making those assessments, and if you don't meet those criteria, then I think it's important for the patient, for public confidence and for medics that the law as it currently stands remains extant, and that what we can't have is situations where people are being assisted to die in ways other than is set out in this bill. Those would remain. The sort of criminal law continues to apply, as we heard from Crown Office and Police Scotland last week.
Thank you. And Joe Fitzpatrick.
Thanks very much. I want to talk about ask about the financial memorandum and some issues around that. Now, we know that you've had an extensive session with the Finance Committee, so I don't propose to redo that, but I will give you the opportunity to respond to some of the points that they've flagged up to us. The first area I was wanting to speak about was, and it has been touched on already, so maybe we don't need to spend too much time, training time costs. So you mentioned briefly earlier. I think you're suggesting 200,000 in the first year, and we've had a figure from the Cabinet Secretary that the Scottish Government believes that training costs for doctors would be something more like 6 million. Huge difference in numbers there. So just give you the opportunity to.
Yeah, I mean, it was an extensive session, but as the Health Committee is finding, I appear to be party to extensive evidence sessions on this topic. I think where this emerged from, to some extent, was the modelling that was used in terms of trying to predict the numbers. And as I acknowledged to the committee, you could make an argument that would see numbers taking up the option of assisted death, and therefore the associated cost being higher. But equally, you could make an argument for them to be lower, drawing on international evidence. I think in terms of the training costs themselves, the numbers likely to be involved in this as a result of take-up are expected to be relatively small. I think a lot of that training is already taking place. I think as I was responding to Ms Whittam earlier on, in terms of assessments of coercion, assessments of capacity, etc., those are assessments that are being taken. So I absolutely acknowledge that there will be perhaps a requirement to update the training that is provided. We're not talking about something that is wholly new to the medical profession. I suppose to some extent I'm at a slight disadvantage in terms of the Scottish Government's assessment, because whereas I've set out a financial memorandum that's kind of shown my working, I'm not clear where the Scottish Government have developed the figures for. I think, again, back to the point that was being made, I think, by Ms Mochan about whether an opt-in and an opt-out service, it may well be that if you're looking to assume that everybody, every GP, every nurse, every consultant needs to have training to deliver a service, the costs of that are going to be greater than if it's done in an incremental way. And again, this probably touches on the question about the implementation period for the bill. What's the expectation? What's the trajectory leading up to implementation and then in the initial years? So, as I say, I think the financial memorandum, as there was collective agreement, I think in the Finance Committee, that this was a very wicked sort of problem to try and get your head around. There isn't an example of a similar financial memorandum having been kind of put in place in other jurisdictions. So it was an exercise in trying to make some reasonable assumptions around take-up and then extrapolating that out over the first few years and then up to 20 years out.
So one of the points that the Finance Committee have made that is that the process of this bill and the happy coincidence or the coincidence that there's a bill going on at Westminster means that awareness is perhaps higher than there has been elsewhere, so suggesting that maybe the earlier costs might be higher than you've envisaged, because I guess when you did your calculations you didn't know that that bill was going to be at the stage it is.
A lonely furrow at that point, at which point Isle of Man and Jersey have picked up the pace, and obviously we've seen developments at Westminster. Look, there's not an unreasonable argument there. I think some of it is around public awareness. Some of it is also around the kind of preparedness of the medical professional to deliver this. So even though this legislation may be implemented, until the medical professionals involved in it have the training required in order to deliver it, then it may be more difficult to access it over those initial stages. And I think it's awareness, but it's also a degree of comfort with the process as well, an understanding of it, not just in theory, but how it works in practice. So I think, as you've seen in Australia, certainly in states that adopted legislation later on, numbers were higher in the first 2-3 years than they were in states such as Victoria, who were the kind of earliest adopters. But by that stage, you still had legislation in place in other jurisdictions, and I'm sure fairly extensive public awareness raising campaigns. So I think predicting the numbers, as I think we agreed almost unanimously in the Finance Committee, is highly problematic. And as I say, I've set out my best estimate of it on drawing on the parallels from Oregon and Victoria that I think give us the longest data set to try and to make comparisons.
Okay. You mentioned Oregon and Victoria, and obviously your cost estimates were based on those two systems. I think most of us, and anyone who's been watching the evidence, will understand why you've done that, but it was something that was raised by the Finance Committee that they'd heard evidence that you should have used Canada. So I'll just give you the option to very quickly explain why Oregon and Victoria and not Canada is the basis. I'm
highly delighted that you asked me that question. I think the thing that maybe confused me a bit most with the Finance Committee's letter to you was I think the weight that was attached to the suggestion that Canada would be a more appropriate model. It was certainly raised by one or two of those that gave evidence. But I think even a cursory scrutiny of the different models in place in Canada as compared to Oregon and Victoria would give you a pretty definitive answer as to why Oregon and Victoria were used. I used both of those because the terminal illness mental capacity model is the one that was adopted in Oregon in 96, 97, and then more recently, but first of the Australian states in Victoria, which means that you've got probably the largest data sets of who's accessing the choice, when, how, etc., and that you're not reliant simply on other demographic factors or whatever that may be at play in the US, but not in Australia. So it was a good comparator, I think, that no two assisted dying laws anywhere in the world are the same, but those two sort of reflected, I think, models that were most closely aligned to the bill I've introduced and give us the largest data set. In terms of Canada, the eligibility criteria are far more extensive than the eligibility criteria in my bill. So it's difficult to see why you would use that as a model to try and understand how and who would access assisted dying were it to be introduced in this country. I was slightly confused as to not the fact that they'd been raised by witnesses, but why the Finance Committee appeared to attach more weight to it than I think was justified.
Okay, thank you. I think that's the main questions that I would want raised from the letter. Thanks.
Thank you, Mr Fitzpatrick. Can I just for a point of clarity, and I did ask the Cabinet Secretary to clarify this last week when he was talking about figures of just over £6 million on the basis of training 50% of doctors, taking into account those who may wish to opt out of the scheme, that your figures are purely on medical staff. They haven't taken into account pharmacy staff or nursing staff, or indeed any other allied health professional.
Pretty sure that it may just be medical staff. I'll be asked.
Yes, thanks.
To answer.
Yeah, just referring to the financial memorandum directly, paragraph 65, we speak there about training required for NHS Scotland to determine anticipated online training, registered medical practitioners such as pharmacists as well, so some account was taken. Not to act to the full extent you outlined, but certainly to include pharmacists.
Okay, but not any other profession who may be involved in the care of someone who was accessing assisted dying?
No, I mean, as I said, the model was built up from an assessment of take-up and the associated costs. So I think I can understand the Scottish Government have taken a different approach to that modelling, which it probably inevitably results in a far higher cost. But as I said to the Finance Committee, I think the approach taken to the financial memorandum was a reasonable attempt to assess those costs. The Finance Committee were also, I think, applying a degree of pressure on me to try and estimate the savings that were made. And as I said to them, that is an even more sort of precarious assessment to try and make, given that it will very much depend on who is accessing at what point in their terminal illness, etc. They're accessing the assisted dying. So it is, I think, a reasonable estimate of the financial costs, and I think point to the fact broadly that this is something that would be cost neutral, recognising that those that are going to be accessing it are in receipt of treatment and care at the moment.
So in view of the letter from the Finance Committee and their determinations, what Scottish Government has put on record and the omissions that you've alluded to in terms of your financial memorandum today, you won't be looking to review your financial memorandum attached to the bill?
I don't think so. I mean, it's difficult to know on what basis I would try to develop a different approach to the financial memorandum. As I said, we've discussed earlier about whether or not you have an opt-in or an opt-out model, and I can see that having a kind of fairly sizable bearing on what your costs would be. But I think working on the assumption that assessing the likely take-up and the associated costs, recognising that you're talking about patients that are going to be in the health system already, you're talking about a lot of the training being training that's already routine and delivered that may need to be adapted, but it's certainly not having to be started from a standing start. And where also I think it's fair to say there will be models and modules that are available in other jurisdictions that would help inform that. I mean, I don't think you can't have a lift and shift because the health and care system here is very different from those in Australia and the US, but at least it provides pointers to how you would deliver that. As I say, I think the financial memorandum remains a reasonable assessment of the likely costs.
And Emma Harper.
Thanks, Convener. Just a final question about the two independent doctors. Are they allowed to confer with each other? I don't know if the bill's explicit in that. And could it be, a doctor at the hospital, doctor in the GP practice? Could it be two GPs under the one practice? What makes them independent? Are they not allowed to confer with each other during the process?
In response to the point about two GPs in the same practice, that wouldn't be permitted. The doctors need to be acting independently of each other, and one kind of had no prior relationship with the patient themselves. The second doctor will have the medical notes, etc., but will carry out their assessment of terminal illness and mental capacity. I don't know if there's anything, Dr. Ward, you want to add to that?
I would just say that I think Section 6 sets out in detail the relationship between them, and again, if you the Scottish ministers are responsible for some regs there as well, but I think it sets out pretty straightforwardly what they can and can't do in relation to the assessment under both Section 6 and 7.
That's fine. Thank you. Thanks.
Is that okay?
Just wanted to clarify that. Yeah.
Can I thank you, Mr MacArthur, for your extensive evidence this morning. I know it has taken quite a substantial amount of time, more than we had anticipated, but I think the committee has certainly been able to ask the questions that previous evidence had presented to them. So thank you to yourself and to your witnesses. And that concludes the public part of our meeting today.